She's both a pediatric cardiologist and an intensivist. She's currently working at Boston Children's Hospital. She's the lead cardiologist within the Ecmo team. She has a vast experience in mechanical circulatory support. And I think that she's going to give a great talk on a topic that I hope to have an answer by the end of the lecture. How we manage failure to wean cardiac ECMO. So this is the holy grail. Peta, please.
Thank you so much for such a generous introduction, and I'm so pleased to be presenting at EuroELSO today. I'm clicking on my slides and they're not moving forwards. Is there a technical aspect to that? Can you advance the slide, please? Thank you. These are my disclosures. So I am clicking on the slide. I think I'm going to need you to advance them. I'm sorry.
No problem at all.
So I'd like to engage with a bit of a mind map with you while we consider failure to wean from cardiac ECMO. So this is how I think of a cardiac ECMO run. Clearly, the timing of cannulation is straightforward. It happens at 0 time point. Clearly, the timing of decannulation is clear. It happens at whatever time the patient is physically decannulated from the ECMO circuit. And we usually think about weaning as happening sometime in the interim, right before decannulation. Next slide, please. But the reality for our patients is that everybody gets onto ECMO under different conditions. And so if I could choose, I'd have an early recognition and identification system for patients who are sliding into low cardiac output, not recovering with the usual therapies that I'd expect to make a difference to their low cardiac output. I'd call in the team and we would electively cannulate patients who are not yet in extremis to cardiac VA ECMO. Next slide, please. But we all know that there are a number of patients who crash onto ECMO instead of that nice, clean slide, either via ECPR from an acute onset event, such as a pneumothorax in a postoperative patient, or a sudden onset arrhythmia, or worse, have an ECPR event after their prolonged low cardiac output. So in addition to the low cardiac output state, they sustain the sudden loss of circulation. Next slide, please. And so there are issues that occur before ECMO cannulation that certainly impact our cardiac ECMO run. Next slide, please. In the same way, decannulation from ECMO can be a planned event after a clear trial of weaning of support, when everybody's prepared and the patient's otherwise optimized with adequate ventilation, a little bit of inotropy on board, and a good fluid status. Next slide, please. But the other alternative is that they come off in a bit of a hurry, either from an inadvertent or poorly communicated decannulation, or because they've sustained a complication of ECMO that means that further ECMO support's no longer viable. Next slide, please. In that context, the period after decannulation is also important for what happens for patient outcomes. Next slide, please. Why is all of this important? We looked at more than 13,000 patients between 2008 and 2013 in the ELSO registry. We looked at all neonates and children who were put on ECMO, and of course, those who are decannulated for organ recovery still have an attrition rate in the period after ECMO decannulation. And we found that attrition rate in the time frame that we looked at was 13% of patients die in the first 30 days after ECMO. Next slide, please. You can see from the graph that those patients can die quite early after ECMO, and so it's possible that they were mislabeled as genuinely organ recovery, but a proportion of them have successfully recovered function on ECMO, been decannulated, and still die. When we looked at those, the higher risk group were younger age, so certainly neonatal patients. Small neonatal patients, less than 3 kilos, were at higher risk than others. Those with a cardiac or ECPR indication were more likely to die after successfully weaning from ECMO. Patients with a longer time from hospital admission to ECMO may have been more complicated, and those with a lower pH at the time of cannulation were more likely to die after successful decannulation. I'm not sure that I'd call complete organ recovery those who receive further mechanical circulatory support, such as VADs, but if patients required VAD support, they were at higher risk. And any patient with a circuit or patient complication during their ECMO run was more likely to die after successfully weaning from ECMO. Next page. So in that context, if we think about our cardiac VA ECMO run with the mind map that we're going to use throughout my talk, the sorts of outcomes that we assess our ECMO run against are certainly survival to ECMO decannulation and hospital discharge. Next slide, please. But I'd suggest that if we're talking to families, they're much more interested in their child returning to usual activities of daily living and getting back to the kid that they used to be. Next slide. We know intuitively that what we really mean by a successful VA ECMO run with successful wean to decannulation is that the patient who's supported for cardio or cardiopulmonary failure recovers organ function over the course of their ECMO run without new organ injury. And that's much more likely to result in survival to ECMO decannulation and hospital discharge and to subsequent return to activities of usual daily living. Next slide, please. This is some local data that Ravi Thiagarajan and I have been working on. We looked at 2 years worth of ECMO patients at Boston Children's Hospital, and the patients are represented by a dot and a line on each of these graphs. We used the PSOFA score, which is a multi-organ system dysfunction score, looking at cardiopulmonary, renal, hepatic, neurology, and coagulopathy function. We assessed patients in the 24 hours before ECMO and the 24 hours after ECMO decannulation, and we separated the patients into non-survivors on this side and survivors on this side. You can see that in the 24 hours before the ECMO run, there's really not a lot of difference in the PSOFA score, with higher scores up to a maximum of 24 being associated with the worst dysfunction and lower scores being associated with less multi-organ system dysfunction. But what's notably different between the two groups, the survivors and the non-survivors, is that the survivors over their ECMO run recovered end organ function. Most of these trajectories are to improvements in their PSOFA score, whereas non-survivors of ECMO had worse multi-organ dysfunction. And this goes back to that recovery of organ function without new injury is what we're targeting with ECMO. Next slide, please. So we're back to my mind map of the cardiac VA ECMO group with outcomes of survival, recovery of organ function, and ultimately return to usual activities of daily living. Next slide, please. But if we break down the way we actually manage patients on ECMO, I think it's fair to say that depending on how patients arrived on VA ECMO, for example, crashing on via ECPR, early post-resuscitation care takes up a lot of our time and energy in the first couple of days. Anticoagulation, management of bleeding or clotting issues persists over the course of the run. I'll come back to hemodynamics of good perfusion and normal filling pressures, but of course for a cardiologist and cardiac ECMO person, those are imperative. But the other aspect of care that we focus on a lot is preventing neurological injury and managing close monitoring for adverse events. And associated with breaking down our ECMO run into multiple domains, I've added in a couple of extra outcomes: survival without new neurological injury and avoiding hemocompatibility adverse events. Next slide, please. But to answer the question that I've been asked to focus on today, more than halfway through my talk, how do we manage ECMO? How do we manage cardiac ECMO runs to best optimize our chances of successfully weaning? I put it to you that it starts before the ECMO cannulation. Pick the right patients, put them on at the right time. And once you've cannulated to ECMO, get really serious about unloading the heart and restoring normal hemodynamics rapidly. And by that, I specifically mean we actively manage every patient who goes on ECMO for cardiogenic shock or ECPR with left atrial decompression. And if our patients aren't either directly left atrially compressed via LA vents, as you've seen in previous talks this morning, or taken to the cath lab for a balloon atrial septostomy in the first 4 to 6 hours after cannulation, we document very clearly in our medical record why that might be, why we chose not to unload the left side of the heart in this patient, because we think it's so important. And the only possible reasons in our population would be that it was an arrhythmia that recovered with cannulation, or that with unloading of the heart, the native heart was ejecting, the chest x-ray cleared, and the echo showed that actually there was really no distension of the left atrium or left ventricle. But we take unloading the left ventricle very seriously in this patient population. The other thing that we take very seriously very early, and that's why the time frame of my mind map is so important, is the early identification of residual lesions. We would do a detailed echo on ECMO for these patients. We'd also have our imaging specialists review all of the available imaging, particularly in a postoperative patient, to ensure that we hadn't missed a lesion. But in addition to that, we have a very low threshold for taking patients for diagnostic cardiac catheterization. And clearly we get the best physiological data if we're in a position to clamp the patient for that cath, but we get an enormous amount of anatomical data from coronary artery angiography, from looking for persistent left to right shunts or AP collaterals that might just be loading the left side of the heart in a potentially restrictive left ventricle otherwise. And so we take early identification of residual lesions very seriously. We also, during the course of the run, try and maintain cardiac ejection. And we would choose to use low-dose inotropes if that's what's required to maintain ejection over the ECMO flow, recognizing that that comes with a downside of increased oxygen consumption of the myocardium. We won't decrease ECMO flows enough to affect end organ oxygen delivery. So we do balance the VO2 required for patients rather than just maintain ejection over very low flows. But with adequate end organ oxygen delivery, our preference would be to have cardiac ejection in addition. And then finally, she gets to the topic of her talk, which is the ECMO weaning strategies. And I've put them at the end of the talk, because at the end of the ECMO run, because that's where we traditionally think about it. But I'd tell you that we start evaluating for readiness for decannulation at about 48 hours into the run, and then every 24 to 48 hours thereafter. But we do it in a way that doesn't induce additional myocardial injury. And I'll go through that a little bit on the next slide. Next slide, please. Thank you. Now, this is a busy slide, and I apologize. I've lost some of my animation, which means you're stuck looking at it all at once. But if you just focus on this assess cardiac function side for me for a moment. So this basically runs through the way we look at cardiac function of patients on ECMO. There's lots of more fancy ways in the literature, but ours is reliable and consistent. And so the way we do it is we tend to wean the flows down from wherever the patient starts in decrements of about 25% of their flow overall cardiac output required. And by the time we get to 70 mils per kilo per minute of flow, if the patient's tolerating that, we'd take a blood gas, we'd assess lactate. Our patients all have central venous cannulas, and so we'd have a central venous saturation. I assess what the heart rate and blood pressure are at that point, as well as the catecholamines or other inotropic support that the patients are receiving. And then we'd stepwise wean down over the course of the next couple of hours through 50 mils per kilo per minute of flow. And if there's no change in vital signs, catecholamine requirement, or lactate at that point, then we'd step down through 30. And if the patient continues to have the same filling pressures, the same blood pressure with an equivalent pulse pressure and not a greater requirement for inotropy, then we'd consider clamping and echo at that point for systolic function, pulmonary pressures, valvular function, and any sign of residual lesions that we haven't detected along the way. And only with clamping for a period of time, at least 15 minutes for us. It takes almost that long for us to get a blood gas back because we're not point of care testing here. Then we'd recognize whether or not the patient had adequate cardiac function for decannulation. Having said that, if at any point along the way the patient shows that they're not tolerating the ECMO flow wean, if the filling pressures rise above a predetermined limit for this patient, for this physiology, then we would stop the ECMO wean, get an echo at that point to make sure that we're not missing something else, and then go back up to full flows and consider how we're going to change our trial for tomorrow. If the patient's inotropic support skyrockets past preset limits, then we would stop the wean, get an echo to make sure we're not missing something, make a plan for how we're going to do it tomorrow. So our intention isn't to wean to clamp at all costs every 24 to 48 hours on ECMO. It's to test the physiology by coming down on flows to a point where we are able to clamp the circuit and assess for adequacy of cardiac function. And that would still be our process. We do still clamp the circuits. So with this as our process, at the end of each trial of wean, we've determined whether the patient has adequate cardiac function or inadequate cardiac function to push to wean towards decannulation. We also determine respiratory function as a secondary step. So the respiratory function is obviously going to be informed by clearing of the chest X-ray from whatever pathophysiology was affecting the patient at the time of ECMO cannulation and throughout. But we'd also look at compliance. We'd expect not quite the same respiratory vent settings that you'd expect for decannulation from ECMO, but we expect to be able to maintain a PEP less than 30 and a PEEP that's not required above 8 to 10 to be able to wean off ECMO for a cardiac indication patient. And if the patient satisfies both adequate cardiac function and adequate respiratory function, then they track down this curve of the figure, and we prepare for decannulation. And we do that either later today or potentially tomorrow if the patient's been on for a long time and we're a little bit more concerned that we need to make sure that there's nothing else going on. If the patient has adequate cardiac function, but their respiratory system is still affected either by pulmonary hemorrhage due to left atrial hypertension, pre-existing ECMO, or other complications of infection along the way, then we would start to talk about converting to Vv Ecmo. But I work in a cardiac unit and we do very little Vv Ecmo. So to be honest, our conversion would be slow. We'd talk about that today. We might get to doing it in 2 to 5 days after another series of weans with interval pulmonary manipulations, including bronchoscopy, weren't able to fix the respiratory function side of things. So convert to Vv Ecmo should be on our minds as a strategy. If, however, we're still stuck at inadequate cardiac function, then we would again assess the respiratory function, because it's possible this is a patient who has an underlying cardiomyopathy and that's why they've landed on ECMO, a myocarditis that's going to take longer to recover, or indeed a post-cardiopulmonary bypass hit that's also going to take longer to recover, and that they're going to benefit from longer-term ventricular support, but as a single organ dysfunction. And then we'd start talking about converting to VAD. And if we, in the same way as Vv Ecmo, we do a lot of ECMO, we do fewer VADs. And so if we were talking about weaning to VAD, we'd establish a plan today to think about it in 2 to 5 days, retest the patient over the next couple of days, and then get them cannulated to VAD next step. And if we're stuck in the situation where the patient has inadequate cardiac and inadequate respiratory support, then clearly we maintain VA ECMO. And we don't have an ultimate time limit for VA ECMO, but rather we take each patient in individually and monitor them for accumulation of complications of ECMO versus signs of some progress on ECMO. And I've got a little bit more about that on a subsequent slide. Next slide, please. That's more specific about the cardiac function. I lost some of my animation in these slides. We'll go to the next slide, please. And so if we just go back to my mind map for a minute, if we fail to wean ECMO for inadequate cardiac or inadequate cardiac and pulmonary support, that would precipitate us going back to this slide and ensuring that we've done all of the steps that we've chosen along the way to make sure that we haven't missed something. So a reassessment of our early identification of residual lesions, a reassessment of whether we're choosing the right strategy to support end organs and maintain ejection, and then a reassessment of the best strategy for this patient for the next time that we trial a weaning strategy. Next page. And in the interim, Katie Moynihan, who's one of the attendings that I work with in Boston, has led this process. And this paper, the paper that this image comes from, is going to be in print in the next couple of months. I encourage you all to have a look. She's led this conversations during Paediatric ECMO support strategy, where while we're focusing on residual lesions and maintaining ECMO, maintaining ejection during ECMO and how we're going to wean and all of the kind of at the bedside pathophysiology factors, we're also helping the family through this path with iterative conversations from day 0 through the variable days 2 to decannulation, such that it's not a surprise if we're talking to them about decannulation with survival possible but not assured. And it's not a surprise if we're talking about decannulation anticipating that the patient's going to do well afterwards. But similarly, it's not a surprise if we're decannulating with end of life anticipated, either due to lack of recovery or progression of underlying disease or accumulation of complications. Next slide, please. So in terms of my approach to failing to wean cardiac ECMO strategies, next line. Prevention is so much better than cure. Set up the whole ECMO run for success so that you're not talking about it on day 6 for the first time. Next line. We manage aggressive left heart decompression to optimize recovery of ventricular function. Next line. We identify and manage residual lesions early. Next line. We manage for native cardiac ejection during the run, if that's possible. And we trial weaning ECMO flows every 24 to 48 hours, but we don't force cannulation if it's clear that the patient's not ready. We don't force clamping or weaning to 0 flows if the patient's clearly not ready by serial assessment on sequential trialing down of flows. Next line, please. And we have iterative conversations with caregivers to build awareness, trust, and shared goals as we go. And I'm going to flick up my last slide, which I should have sent to Ariane given the topic of her talk, which is pure advertising for the Paediatric ECMO Anticoagulation Collaborative, which results should be out early next year. Ariane leads one of our very important subgroups in this.
Oh yeah, fantastic. Thank you, Peta. It was a great talk. And I think that at the end, fingers crossed, right? To see whether we're going to succeed or not.
Isn't that the truth?